To invite Dr. Prithvi from BIOS to give his talk on surgery intraocular tumors.
Thank you very much. I hope you can see my slides.
Yes, Prithvi.
We're good. Great. Thank you to the committee and my good friend Raja for this invitation, and to everyone wishing your families good health and safety in these trying times. These are my disclosures. And I was asked to discuss whether we as retinal surgeons should be doing retinal surgery in eyes with tumors. So we have a very esteemed panel here today, but I convened my own panel to see if they could answer the question, and let's see what they said. It looks like the panel that I've chosen does not feel comfortable with retinal surgeons doing surgery in eye with tumors, but I think we'll see if there may be some exceptions to this. And as vitreoretinal surgeons, the main indications for surgery in these eyes are mainly for diagnosis and prognosis, treatment, either primary or secondary, managing complications, and in rare cases, for eye salvage. So we'll discuss these various considerations. When we look at diagnosis and prognosis, the most common intervention would be a choroidal biopsy. There's an increased use in uveal melanoma with genetic testing, with commercially available to determine prognosis, and an increased exposure to ocular oncology in many vitreoretinal fellowships. So we've been proponents of using 27-gauge vitrectomy instrumentation to do biopsies in patients with choroidal melanomas. I use a 3-port 27-gauge setup, which allows for good visualization with the inverter. We use the cutter to go straight into the tumor without doing a full core vitrectomy and engaging with high aspiration and low cut rate. And we basically take the sample, pull it out with the cutter. You may find a little bit of bleeding, but usually it's quite minimal. And when it comes out of the eye, we can expel the contents into a tube, and that can be sent for diagnosis as we need it, either for genetics or for use for diagnosis. Sometimes doing an intervention can be both diagnostic and therapeutic in its intention. This is a 66-year-old gentleman with blurry vision and a headache, had a previously normal CT scan, but was noted to have a retinal detachment and a choroidal mass. Of note, he has a 40-pound weight loss, is a diabetic, and has a history of hepatitis C, and is a former smoker. Here we can in the macula, as well as a rhegmatogenous detachment with an inferior hole, but we don't know where the primary tumor is in this case. So we did a combined diagnostic choroidal biopsy and a therapeutic repair of the retinal detachment. So we proceeded by placing an encircling scleral buckle and proceeded with 25-gauge vitrectomy, where we first identified the choroidal tumor and also the inferior retinal break. We did a peripheral vitrectomy in this case, which is because of the therapeutic intent. I aspirated some clear fluid and then a little bit of air up to the first connector, and we come up to the tumor site and come up to the edge of the tumor in an avascular location, put a little pressure on the retina and pop the cutter right through the tumor, reduce the cut rate, and obtain our biopsy specimen. We can come out, there's a little bit of minimal bleeding, which we can manage, and reflux automatically into the collection tube, and we can see multiple abundant small tumor fragments that we can use for assessment. And then it becomes the repair of the retinal detachment with endolaser. And as we flatten the retina, we notice that this patient actually had a second site of a multifocal biopsy metastatic lesion. The final diagnosis was metastatic esophageal carcinoma, and the retina remained attached on final follow-up. The second indication is to treat either primarily or secondarily the tumor itself. So we are aware that there's a lot of data on the use of vitreoretinal surgery in eyes with melanoma, either as primary treatment or to deal with secondary side effects. The treatment complications are usually what spur the retinal surgeon to treat these eyes, either vitreous hemorrhage, traction detachment, retinal detachment, but often it's uncommon, not often necessary, but it can be done safe and effectively. But I use it more in a conservative approach on these patients. Endoresection is a primary way to treat tumors that are required to be treated in eyes that maybe radiation may not be favorable, either tumors that are nasal to the optic nerve in an only eye, or those that may damage vision with treatment. It can also be used in the post-brachytherapy setting in eyes that have high levels of ischemia in terms of the, quote, toxic tumor syndrome. This is done with a vitrectomy probe to control the removal of the tumor tissue. Secondary retinal detachment will be induced, and that has to be repaired. Often these eyes require hypotensive anesthesia, and there may be adjuvant brachytherapy. As note, there are some complications, including the risk of venous air embolism during the vitrectomy that has led to some very sad cases of fatality. Here's a case of a large tumor nasal to the optic nerve, nearly 9 millimeters in thickness, first treated with plaque brachytherapy. And here, in a case shared by Dr. Zelia Correa, we can see the 23 gauge vitrectomy being performed, the large detachment at the site of the tumor. A biopsy is taken to obtain confirmatory cytopathology and genetic testing, and then the cutter goes in and you go to town. And the cutter eats away not only the retina overlying it, but also the tumor tissue itself. There's often abundant bleeding, which requires elevation of the bottle, and the hypotensive anesthesia can be helpful for it. Blood clots can be removed, and then finally the detachment is repaired. For the vitreoretinal surgeon, complication management becomes important as well. Here's a case of neovascular proliferation that's being managed with bimanual technique in a patient that's had a melanoma and subsequently developed proliferation and traction detachment. But retinal detachment itself is kind of the main indication for vitreoretinal intervention, and retinals detach in ocular tumors mainly for either tumor factors or for tumor-independent factors that may develop. And often these are combined mechanisms that come into play. Here's a 69-year-old patient with a peripapillary melanoma that was treated with brachytherapy. The visual acuity is quite good, and had adjuvant transpupillary thermotherapy as well. There's good tumor regression, but there appears to be persistent subretinal fluid and a demarcation line where we suspected that there was an atrophic break. So the patient underwent vitrectomy surgery. Here we can see the lifting of the hyaloid. We can see the placement of perfluorocarbon to stabilize the posterior pole, and dissection away with both forceps and bimanual technique with a lighted pick to clear the hyaloid into the periphery. Full peripheral shaving is performed, and a candidate break is identified, and the retina is then repaired and endolaser placed around the tumor and the break. I always sutured these sclerotomies, and I always place cryotherapy at the sites for protection. A patient here with retinoblastoma treated with intraarterial chemotherapy and intravitreal chemotherapy who had a persistent temporal retinal detachment. And retinal detachments are now seen in the post-chemotherapy area, even after external beam radiation, systemic chemotherapy, and up to 6% of eyes with intraarterial chemotherapy. In operating in eyes with retinoblastoma, it's important to know whether the disease is under control, what is the visual potential, and management of things like vitreous seeds, and also the concern about orbital seeding is always there. It is true that inadvertent vitrectomy has been performed on eyes with retinoblastoma. In this series from the LV Prasad Institute, Swati Kaliki shared 14 children who had inadvertent intraocular surgery, often thought for endophthalmitis and either vitrectomies or eviscerations, and presented with advanced retinoblastoma, including extraocular extension and orbital optic nerve extension. And in this, sadly to say, nearly 57% of these children ended up with progressive disease and passed away. So we talked about Salvage, finally, and a controversial technique that's being done in China is in eyes that are monocular with bilateral retinoblastoma, heavily pretreated, and in order to avoid enucleation, 3-port vitrectomies performed with melphalan infusion. With 3 years of follow-up, 18 of these eyes have been salvaged with no deaths reported, and 14 of these eyes have had functional vision. So we'll learn more about the long-term outcomes of this technique called tylectomy. So we've talked about the various indications for vitreoretinal surgical intervention. I'll leave you with my take-home points. Number 1, avoid surgery in untreated retinoblastoma eyes. Confirm inactivity or non-malignancy of the tumor before you go in. Send the cassette for cytopathology just to be safe and sure. Suture all your ports and cryo to the surface of those ports, and confer with your ocular oncology colleagues, and pause. Not all of these eyes require surgery. Thank you very much for this opportunity.
Thank you, Dr.
Dr. Raja, can I just have a quick word?
Yeah.
Yeah. So, Partha here, and welcome to the last day, the 4th day, and the morning session. Thank you very much. Very, very special word of welcome to Dr. Christina and Dr. Prithvi from US. And thank you, sirs. Thank you, madam, for being with us today. I hope you have had a good experience, and I'm very sorry for all the technical glitches that have occurred. Thank you very much. Please carry on.
Thank you, sir. Just I would like to ask which Dr. Sandeep had put in the chat box as an open question to Dr. Prithvi. She was asking about the precautions to be taken to prevent venous embolism during resection, actually.
Yes, it's and briefly, I'll say that I don't think we know enough about that situation. We would try to avoid air infusion if possible, but I just learned of a case from the Moorfields Eye Institute of an eye that had an endoresection, no air infusion, only perfluorocarbon used to stabilize the retina, and the patient still developed what appears to be an air embolism. So I think we don't know exactly why and what is causing it. Obviously, high pressure air infusion where you have Barrett's sclera is a concern, but I think we'll be learning more as these cases are being combined across the world. So with caution.
Thank you.